great pleasure to introduce Fernando Hartwig, who many of you know from before. He's on current visit until February the 12th. He's available for bar mitzvahs, weddings, and whatever. And he's going to talk to us about the Pelotas cohort.
Great.
Cohort.
All right. Take my mask off so people can understand me a little bit better. Thanks, George. Thanks, everyone, for joining remotely or here on site. Now we have already a much larger in proportion audience in relation to the last seminar, so that's quite a good thing, I suppose. So in this seminar, I just wanted to provide sort of an overview of the Pelotas birth cohorts. I don't want to go too deep into specificities of some of the results I'm going to be showing today. But the idea is to present these cohorts, try to convince you that they can be useful, and also share some results from these studies that show quite clearly that social determinants are very important in shaping health and development. So that's the structure of the presentation. I'm going to start by discussing a little bit what birth cohorts are and why we care about them. Then I'm going to present the Pelotas birth cohorts and hopefully provide some context so you can understand why we want to do birth cohorts in Pelotas. Then I'm going to just share some results looking at the association between early life poverty and some measures of health and development in those cohorts, and then just some final comments at the end. So starting off with birth cohorts, this is an open seminar, so I didn't want to assume that everyone was super familiar with epidemiology, so I just wanted to spend a few seconds trying to summarize epidemiology in a single slide, which is a very difficult task. Starting off with a definition, we can understand epidemiology as the study of the distribution of health disease states, as well as their determinants in some population that we are studying. Perhaps this definition is not very useful if you're not familiar with concepts such as distribution. So let's try to understand epidemiology by looking at some questions that epidemiologists can be interested in answering, such as what are the most common diseases in a given population? What are the main causes of death, again, in a given population? How health and disease indicators varies, say, between populations or over time in a single population? We can also ask questions such as if there are any factors, that is, any characteristics of individuals or of populations that are correlated with higher probability of having a particular disease. And from correlation, we can also go one step further and think about causation. So one question that epidemiologists are interested in and actually have already answered quite conclusively is that smoking is a cause of lung cancer. And those things can furnish, policy making. And now we know that we have very good examples of this, for example, in Brazil, that policies aiming at reducing smoking lead to reductions in the rates of lung cancer in the population. So those questions, they're really just illustrations of the many things we can be interested in when we do epidemiology, such as description or surveillance tasks, identifying causes of diseases, designing and evaluating interventions, and many other things. If you want to do epidemiology, and if you want to do epidemiological research, we need to measure a group of individuals. When I say measure a group of individuals, I mean we need to collect data on a group of individuals. And those individuals should be selected in such a way that they are representative of the population that we want to study. So if I want to study, say, the adult population in the urban area of Pelotas, then the group of individuals that I select for my study should be more or less representative of this broader group, which is my population. And I think this issue of representativeness, it's getting a little bit overlooked in some modern studies in epidemiology. And this is a quite a vague statement, like we need to collect data on a group of individuals. And there are many ways that we can do this, and those different ways correspond to different epidemiological studies. And one of such studies are what we call birth cohorts. And we can understand a birth cohort as an epidemiological study that has two main characteristics. The first one is that the individuals are enrolled in the study right after birth, or you can actually do it before birth if you're recruiting pregnant women. And the second defining characteristic is that the same individuals are measured more than once, and indeed, typically several times over their life course. So here's just a schematic representation of what a birth cohort is. So we have, a group of individuals that we want to study, and we enroll them in the study right after birth, so at age 0, and that will be the baseline of the study. And then we measure the same individuals several times during their life course. Those ages here are just examples. You don't have to do necessarily 6 months and then 1 year and then 2 years. These are just examples. And what is going to happen for sure is that the number of individuals that you have in your study is going to decrease over time due to factors such as death, migration, and other things. And so now that we know what a birth cohort is, the next question should be, why do we care? Right? Why do we care about birth cohorts? And this type of epidemiological study is very useful to study long-term effects of early life factors. I mean, that makes sense, right? If you include individuals right after they were born, then you keep on measuring them over time, you have the perfect setup for studying long-term associations. But then one could ask, why not save time and just do a cross-sectional study that is just measure individuals at one point in time, and then ask them about what happened in the past. You would save a lot of time, a lot of money, right? There are many limitations to this. One of them is, measurement error. There are going to be recall issues. There's only going to be possible to measure things subjectively. I mean, in most of the things at least. And all this introduces error in our measures. And another point that's relevant to this presentation is that we can only include survivors. That is, only individuals that survived up to that age, right? And if we're thinking about the role of social determinants, in health and disease, the survivors are likely to be, on average, more privileged than the ones who did not survive. So that would be very bad if you want to study social determinants of health. You're going to be excluding, essentially, those that you want to include in your study. And you're also going to be prone to some types of bias that I'm not going to discuss today. So birth cohorts are useful and they are not prone to this kind of limitations. But as you can imagine, they are complex, very time consuming, and therefore expensive. And this complexity and cost is particularly important in lower income settings, like Pelotas, because we just have less money to do research, right? So those issues become prohibitively in some situations. But we just discussed that those studies are very useful to study long-term associations. So should we just leave low-income settings behind in this aspect? Because the funding is often lower in those settings. Or should we try to do something about it? And what I'm going to be presenting now, it's one of the earlier examples of large-scale population-based cohorts in lower and middle-income countries, which are the Pelotas birth cohorts. So first, some geographic context, right? You can see here on the map, Bristol, where we are, and Pelotas, where the cohorts are. So that's the trip I took to come for this visit. I left Pelotas, traveled along the coast of Brazil to São Paulo, And then I took a flight from São Paulo to London, and then a bus to Bristol. And here is a zooming in Brazil. So we can see here that Pelotas is right about where I'm pointing at the map. You can see my pointer, right? Can you see it? Can you?
Yeah.
Okay, good. So Pelotas is right about there. So at the extreme south of the country, very close to the border with Uruguay, but also at the coast because Brazil does this, right? So a little bit about Pelotas. Pelotas is a medium-sized city in the extreme south of Brazil, as we just saw on the map. And it is, quote unquote, capital of the certain portion of the state. And to be more precise, Pelotas is the satellite city of the south intermediate region of my province. So it's not a formal capital, but it's kind of like the informal capital of that region. Here I'm just showing my province. Here at, in the upper figure, and the entire UK in the same scale in the lower figure. So just to have some idea of dimension. And what I want to show with this table is a comparison between Pelotas, Brazil, and Bristol, just to provide some context and for you to understand Pelotas a little bit better. So in terms of population size, Pelotas is smaller than Bristol, but the total area is much bigger. Pelotas is a very big city in terms of area. The rural area of Pelotas is massive. But the population density is much lower, as we can see by comparing Pelotas with Bristol. Looking at some indicators now, the Human Development Index of the city is 0.74 in 2010, was 0.74 in 2010, which is quite similar to Brazil in the same year, and much lower than Bristol, right? The Gini index, which quantifies inequalities, is similar in Pelotas and in Brazil, and worse than Bristol. The higher the number, the more inequality you have. So we can say that you have more inequalities in Pelotas than in Bristol, say. And to me, the most striking comparison is the last one, infant mortality. Again, Pelotas similar to Brazil overall, but look, compared to Bristol, it's way bigger. So this suggests that in Pelotas, we still have a big proportion of the population that is very vulnerable in comparison to Bristol, at least. Okay. So this is just some context. So what we saw in the previous figure is that Pelotas is, and big quotes here, representative of many cities in Brazil. And the thing about it is that we have a lot of heterogeneity in the same city, so we can capture different realities depending on the subgroup of the population we look at. We have substantial social inequalities as evidenced by the Gini index, and especially the high infant mortality rate. And this is bad. It's bad to have social inequalities. But in terms of research, it's actually useful because it allows you to study social determinants of health and development. So my desire would be that Pelotas would be terrible to study social inequalities. But, terrible because everyone is good, not because everyone is bad. But because we have inequalities, then we better take advantage of it and use the city as a place where we can study those things. If you go back to 1982, and this year is important because it's the year that we started the first birth cohort in Pelotas, registered data that we had was overall very bad. So it wasn't reliable data. And this means that primary data collection was required for reliably measuring health indicators. And this was one of the big motivations for the Pelotas birth cohort, which actually started as a cross-sectional study, and then it became a cohort over time. And again, back in 1982, when the first birth cohort in Pelotas started, back then, most large birth cohorts were in high-income countries. And this was bad in the sense that this was leaving research questions that are relevant to lower income countries, unaddressed, right? So it was useful to start a cohort there that we could use to answer questions that are of relevance to lower income countries. Okay, all nice, all beautiful, let's do a cohort there. Who is gonna do it? Who is gonna put in the work, right? And here it's time to pay tribute to two brilliant epidemiologists based in Pelotas, Professor Cesar Victor and Professor Fernando Barros. I had the honor of having Cesar as my PhD supervisor, and we still work together now as colleagues, although it's weird to me to call Cesar a colleague. And here is a picture of our research center in Pelotas. So you're very welcome to visit. I know some people from Bristol have been there already. And hopefully they had a good time. So if we have the cohorts now in Pelotas, we can thank those two guys. A lot more people, obviously, but those two guys especially. So what are the cohorts and who is enrolled in the cohorts, right? So the way it works is that for every year of these 4 years, say 1982. So in 1982, all individuals born in maternity hospitals in Pelotas, whose mothers lived in the urban area of the city, were enrolled in the study, which means that from January 1st to December 31st, maternity hospitals were visited daily by a research team. And this happened in 1982, 1993, 2004, and 2015. So we have 4 birth cohorts now. Each one started in one of those years. And as in any birth cohorts, individuals were followed up on several occasions with especially high frequency throughout childhood, because a lot of things have changed very fast during that period. So it's useful to measure individuals very frequently during childhood. And here's just an overview of the cohorts. Here is the year, and below, the number below is the sample size that we started at baseline. The number obviously goes down because natality rates are going down. And I'm just highlighting here in red the visits that we did in each one of those cohorts, where we aimed at measuring the entire cohort, and in yellow, just when we targeted subsamples of the cohort. So we see that in Pelotas 82, for example, we had several yellow marks, that is several follow-up visits targeting subsamples because we didn't have a lot of money. The same, but now a little bit less frequent for 1993, and for 2004 and 2015, we are only targeting the entire cohort because now the group is famous and we can get money from funders and all that. So it's just an overview of the cohort, not a big deal here in the picture. I mean, it is a big deal to have that, right? But not in the sense of what I'm going to present today. So now I wanted to share with you some results where we looked at the association between early life poverty and some health and development outcomes. And I'm going to be presenting results focusing on the 1982 cohort. That's because it's the oldest cohort, so we can study long-term associations. The other ones are, younger, so we have some, time limit there. And I'm going to take this sort of life course perspective in the sense that I'm going to start looking at early life outcomes, then physical and cognitive development in childhood, then some measures of human capital, like, IQ, schooling, that stuff, and also some measures of mental health. But for early life outcomes specifically, I'm also going to be showing some comparisons between cohorts to look at what's happening in Pelotas over time. So not the same individuals over time, but the same city over time, but different individuals. So all in the same age. So starting with early life outcomes, starting with the earlier stuff first, I suppose. So one of the things we can look at in Pelotas, for example, is the proportion of mothers who attended at least 6 antenatal visits during pregnancy, and this is just an indicator of like sort of proper antenatal care. The red bars here correspond to the poorest subset of the population, and the blue bars correspond to the wealthiest subset of the population. And the bars in between, I guess you can guess what they mean, right? Just going from poorest to wealthiest, from left to right, for each one of the cohorts. So, I mean, the social gradient, it's clear, right? Here, I don't even need to show any p-values here, right? It's clear that, the proportion of mothers who attended at least 6 antenatal visits is much lower among the poor than among the wealthy, right? But how did this change over time? Let's try to look at it. So the gap size, and when I say gap size, what I mean is the difference between the blue bar and the red bar. That's the gap size, right? In 1982, this was 40 percentage points. So a massive difference. In 2015, this was 26, rounding the number, right? 26 percentage points. Still a big difference, but 26 is smaller than 40, right? If we compare again, though, the wealthy group and the poor group, now not one minus the other, but in relative terms, we see that this proportion was 90% more frequent among the wealthy compared to the poorest subgroup. And when we go to 2015, it was just 36%. Still, it's not a small number, but it's smaller than it was in 82, right? So we can say that although we still see some inequalities in 2015, it's not as bad as it used to be in 82, right? So there's still room for improvement, but at the same time, some improvement has happened already. Okay. So now the same thing, just changing the outcome. Instead of looking at antenatal care visits, we're looking at the prevalence of low birth weight, which is an indicator of poor development in utero. Of course, it has limitations, but let's just stick with that. In 82, what do we see? A clear social gradient as well. So much more common in the poor compared to the richest subgroup of the population, right? And this is a bad outcome. So that's why the association is reversed in comparison to the previous one. If we go to 2015, we see a different pattern of inequality, what we call bottom inequality, where the poorest subset is worse than all others. And that's what we see there, right? We see in 2015 a higher prevalence of low birth weight in the poorest subset. And in the other ones, it's pretty much, the same, sort of going up and down as we go through all the other groups. This is partially due to the fact that C-section rates increased in the wealthy subgroup of the population, and this is associated with low birth weight. But even with that, we still see this pattern of bottom inequality, right? And again, both the gap size in absolute and relative terms decreased over time, which is good news. Infant mortality, so deaths per 1,000 live births. In 82, among the poorest, it was 62. So 62 out of 1,000 live births died during their first year of life. That's a massive number, that's a huge number, right? And in the wealthiest subset, it was 16.7, still big number. So, a massive gap size, both in absolute and relative terms, and a clear social gradient. Here I'm not dividing the population in three groups. I'm dividing I'm not dividing in five, I'm dividing in three, because the numbers are much smaller. So to have better resolution, I just did three groups instead of five, but the interpretation is the same. When we go to 2015, what do we see? We went from 62 in the poorest to 12 in the poorest. So in 2015, the poorest are doing better than the wealthiest in 82. So a massive reduction in infant mortality rates over time. But we saw some slides earlier that in Bristol, overall, it's 2.9. And in Pelotas in 2015, only looking at the wealthiest subgroup is 6.7. So there's still a lot of room for improvement, right? So again, clear social gradients, improvement over time, but a lot of room for improvement, for further improvement. So now we're done with comparing cohorts. Now let's focus on the 82 cohort, because it's the oldest cohort. So we can look at things from infancy to adulthood. In this slide, I'm showing measures of physical and cognitive development in childhood. In terms of cognitive development, I have this intelligence test here applied when the individuals were 4 years of age. And here I'm just looking at the average value of this test among different groups of the population. So comparing the poorest, the sort of mid group, and the wealthiest. And we can clearly see that the average value of this test varies, increases as we increase the sort of socioeconomic position at birth. But what does that mean, like going from 93.5 to 107.6? So what does that mean? One way to try to understand this is the following. Suppose we take the entire cohort. We don't divide, we take the entire cohort. And we look at the values of this test in the entire cohort. If we take this value here, 93.5, about 27% of the cohort has lower values than 93.5. So this will be the sort of lower end of the entire span of the values of the test. When we go to 107.6, we see that 71% of the cohort has values lower than that. So it's in the other side of the coin. So we are going from 27 to 71. So it's a big difference. So that's just a way of trying to make sense of this difference. The bottom line, if you are born wealthy, you have much better chances of developing in terms of cognition as measured by this test compared to other socioeconomic subgroups of the population. Now, if you look at physical development as measured by stunting at ages 2 and 4, I mean, I don't think I need to say anything, right? Just a clear social gradient as well. Much higher prevalence among the poorest subset, the red bar, compared to the wealthiest subset, which is the blue bar. And if we look at the prevalence of stunting at 2 years of age in the poorest subset, it's almost 30% in 1982. So 1984, right? The individuals were born in 1982. They're 2 years of age. So this was back 1984. So back then, almost 30% prevalence of stunting at 2 years of age among the poorest subset of the population. So that's a huge number, right? And if we divided the population further, we could probably find even higher prevalences. So we saw that poverty is associated with lower or impaired physical and cognitive development in childhood. Does that impact you as an adult? So let's try to understand that looking at this figure where I'm showing the association between socioeconomic position at birth as measured by family income. This is the poorest subset, so I'm going from poorer to wealthier from left to right in the graph. And I'm showing three measures of human capital. IQ, which is the black line, schooling, which is the red line, and monthly income as an adult. This is all, those are all measures in adulthood. And monthly income is the blue line. So, I mean, just looking at the figure, you see that, you know, there is a very strong positive association. The wealthier you were when you were born, the higher you're gonna do, the better you're gonna do in terms of IQ, schooling, and income when you're an adult. But like, how big are those differences, right? Well, I mean, if I change the scale of the graph, it can seem to be much bigger or much smaller, right? So how can we understand how big those differences are? Let's try to do that comparing just the wealthiest subgroup to the poorest subgroup, right? Let's just focusing on those to try to understand how big those differences are. In terms of schooling, this difference is of 6 years. How big is 6 years? Well, high school takes 3 years, right? So I would say that 6 years is a pretty big number. Monthly income. The difference between the wealthiest and the poorest was 800 Brazilian reais, which is the Brazilian currency. What does that mean? What does that even mean to you guys? The minimum wage in 2012, which is when we took those measures, was 622. So the difference was substantially greater than one minimum wage. So I mean, we are talking about big differences here, right? And this socioeconomic position refers to when you were born. So notice how things that happen when you were born can have sort of long-lasting associations with, you know, human capital, for example, which results in what some people call lower stocks. So you have, you know, less training, you have lower IQ, so, you know, you just have lower stocks of human capital. But, you know, the problem doesn't stop there. So here's the same figure that I've shown before, and the figure to your right is a very interesting figure. So the red line in the figure to the right corresponds to the poorest subset of the population, and the blue line corresponds to the wealthiest subset of the population. And what am I showing here in this picture? I'm showing the association between the IQ that you have at age 30 on the x-axis and your income at age 30 in the y-axis. So what do we see here? We see that if you were born wealthy, then having higher IQ helps you a lot in terms of income, because the line is very much like this. However, if you were born poor, then having higher IQ doesn't help you that much, right? Because the line is much closer to horizontal compared to the red line is much closer to horizontal compared to the blue line. So not only lower socioeconomic position at birth reduces your human capital stocks, it also make them matter less. So it's a sort of double burden on the poor from this perspective. Now, looking at mental health, I said health and development, so I better, you know, include a health outcome here. Why not mental health measures, right? Here again, those two were measured in age 30. So when individuals were 30 years of age, here is just a score of sociological symptoms called SRQ for people who work with that. which ranges from 0 to 20. And here we can clearly see again that, the wealthier you are, the lower you score on this this test, which is what you want, because the higher the values, the sort of more sort of symptoms you have. And the bar chart to your right, again, the red bar is the poorest subset of the population. The white bar is the wealthiest subset of the population, and we're going from poorer to wealthier, from left to right. It's just the prevalence of depression at 30 years of age. And we can see again, it's much bigger among those who were born poor compared to those who were born wealthy. And among those who were born poor, the prevalence is higher than 20%, which is, it's a lot of people. So, well, that was pretty much the content of my presentation. I just wanted to say, very quick final words before I hand over to questions. I hope to have convinced you that birth cohorts are useful to study the long-term effects, or perhaps I should say associations, of early life factors. And especially in lower income settings such as Pelotas, those studies allow studying the sort of long-term associations of social determinants of health and development. And I do believe that the results I shared with you today demonstrate the importance of social determinants, in shaping health and development. I didn't show any p-value, any confidence interval, and I think everyone is convinced anyway. And I think this sort of body of results and many other results that I wouldn't have time to show here show that poverty is an old but still persistent major health problem that affects people's development, human capital, their health, and many other dimensions of their lives. And for that reason, social epidemiology is very important, and it's a key field of epidemiology for detecting those inequalities and furnish the development of equity-oriented interventions. We have many other results in social epidemiology from the birth cohorts, and people actually publish them in books. So this we could translate this as like, inequality epidemiology or social epidemiology or something like that. Here is just a newer edition of the book. And on the last picture, there is the sort of second edition of the book, which is pretty much what appeared in a special issue of the IGE, I think last year. And last year or the year before that, with the pandemic, we lose our time reference a little bit. And the picture here is just showing Cesar holding the book. And I include the picture here because I wanted to take the moment to pay tribute to him, because he's just a genius guy and very kind person. And to me it was an honor to have him as my PhD supervisor and to continue to work with him to this day. And thank you for joining in on site, and also people who joined remotely. And I'll be very happy to take questions.